Hello and good evening from India. I'm Dr. Jasmine Marwaha and I welcome you all to Global Interdisciplinary Summit 2020. Today we have another eminent speaker and it's a pleasure moderating his session for the second time. So with tremendous pleasure, I welcome Digital Smile World Master Dr. Mark Wovis. Thank you for joining us, sir. So let me quickly go through his introduction. Dr. Mark is the owner and clinical director of Enamel Restorative Cosmetic Dentistry, a private practice in Cape Town, South Africa. His practice is limited to aesthetic and complex restorative dentistry. Mark has been a fellow of the International Congress of Oral Implantologists since 1997 and is a speaker for ITI. In 2010, he founded the South African Academy of the Aesthetic Dentistry, for which he is now a past president. He was the Congress President for the World International Federation of the Aesthetic Dentistry, held in Cape Town in 2015. In 2018, he founded the Digital Dentistry Society of South Africa, for which he is the president. Dr. Mark has pioneered the development of digital smile design in South Africa. He is a DSD World Master and also a DSD instructor. If that's not enough, Dr. Mark teaches courses for removable adult orthodontics for the International Group Intelligent Alignment System IAS, and also teaches aesthetic and restorative courses for the Implant and Aesthetic Academy in the South Africa. Dr. Mark has recently been invited to be a silver member of the prestigious group Style Italiano and an ambassador of Slow Dentistry. So today he'll be talking about treatment of tooth fear using predictable digital workflow. So I'm sure that everyone will enjoy and learn something new today. So it's a request to the audience, please post your queries in the comment section. So before moving ahead, I would like you guys to go through the link in the description box. Thank you. Over to you, sir.
Thank you very much, Jasmine. That's a beautiful introduction, and I'm sure that I will do that introduction justice. So let me just open my presentation. There we go. We can see that. Yep. Okay. So again, thank you very much for having me. Well, sorry about that. 1 second. Not sure what happened there. Let me open up. Right. You can see it okay?
Yeah, we can see the
perfect. Okay, thank you very much anyway for allowing me just to share my experiences in restorative dentistry and certainly in digital dentistry, and highlighting, I think, an interesting problem in dentistry today, which is tooth wear. I think that it's really a global problem, like the global problem we're faced with sadly at the moment. And I think that it's a problem that I certainly see in my clinic in Cape Town on a day-to-day basis. And so I'll take you through the workflows the digital workflows that have certainly made the restorative process seamless and predictable for our patients. So 1 second, I'll have to do that. Okay, it's just not playing. Okay, I'll take it manually. Sorry. There we go. So if you would like to follow me, let me just go back one. You'll see that also I'm working with the Implant Aesthetic Academy. If you would like to follow me on Facebook, Mark Bowes, Doc Mark Bowes on Instagram, and certainly have a look at our website, enameldentistry.co.za. So in 2020, I think that one of the, if not the most important thing, is that we need to listen to our patients' needs, and we need to treat our patients' needs in a very conservative way. So what we talk about is patient-driven dentistry, and it's specifically targeting the needs of each case. That, as I say, we work in a minimally invasive, certainly in restorative dentistry, and we do the least amount of dentistry, but obviously to give our patients always the best final outcome. The thing that really has changed for me as a restorative dentist over the years is the ability to plan cases and the need to plan cases. And certainly from a digital point of view, the planning is the key. And it's the key, I think, to all restorative, implant, orthodontics, periodentistry, that the more we plan and the more time we spend planning, the more predictable our outcomes will certainly be. And if we talk about the digital world, I think that getting future ready, as we say here, is the past, because the future really is here in terms of digital dentistry, and the benefits are that we can design and plan, that we understand treatment. And when I mean understand, it means that as a team, as the dental team and our patients, we totally understand any treatment before we get ready to provide those cases, depending what they entail. If we look at the workflow, we talk about initially digitizing patients. And what does that mean? It means putting together a virtual record of the patient, CBCTs, digital photographs, facial scans, and intraoral scans. And then with that, with these files or with this information that we have stored in a very convenient way, we can start to create a virtual treatment for that case, bearing in mind every treatment is different. So once we've created this virtual treatment, and if there are mistakes to be made, this is the time to make them, because when we start treating cases, we don't want necessarily for things to go wrong, of course. And so once the treatment has been confirmed, we can provide the team, the patients, a presentation, a digital presentation of the realistic outcome. And from then on, the dentistry becomes a guided, which is obviously much more precise. And more importantly, these days, we have the ability, when we've finalized the case, to check how accurate the plan was, the virtual treatment plan that we created for that patient. And this is a super important process. So the case we're going to look at today, and we're going to look at just one case, was the patient that came to see me. And his main complaint that he was unhappy with his smile. He wanted an aesthetic improvement on the deterioration of his teeth that had resulted in certain features, which we'll reveal in a little while. He also said to me, interestingly, that he had noticed relatively in a short time that his teeth were disappearing, which was interesting. And that they had become super sensitive, especially to temperature. The treatment history was that when I asked him, he had had relatively poor maintenance protocols. In other words, he said that he had attended dentists or our profession on a fairly regular basis, but he had had very little maintenance in terms of preventative process to slow down the problems that were clearly happening in his mouth. And it was also interestingly coming to see me for a third, I think maybe even fourth opinion as to what were his options. He was clearly unhappy with the options that had been given to him. And so he had ended up in my practice looking for a further opinion as to what were his possibilities. So if we look at an intraoral picture, what we see is that he has a relatively traumatic edge-to-edge occlusion, almost in crossbite in the lateral, upper lateral and canine areas. He's certainly showing signs of tooth wear on the facial surface of the... Yes?
Sir, you need to change your slides. You need to change your slide.
Oh, okay. They're not going forward? Okay.
Yeah.
Okay, so sorry. Do you know what the problem is? I'm going to start again if you don't mind. Okay, so the problem is, you can see my presentation now?
Yes, perfect.
Is that perfect?
Yeah, we can.
And it's changing now?
Yes. Please change.
Oh.
Yeah.
I'm changing. It's changing?
Yes.
Okay, so I've been through 3 slides now. Sorry about that. I think there was a problem in the connection. So we were talking about, I'll run through these slides quickly, about designing, planning, and most importantly, understanding treatment. I think in the past, without digital workflows, the biggest problem was trying to explain the nature of the treatment that we were proposing for our patients. And with this digital era, it's really super easy that our patients understand exactly the nature of whatever that treatment is we're suggesting for them. And then we're going to talk about performance. And you can see now on the next slide that I was talking about this workflow where we're digitizing the patient, we're creating a virtual record of the patient, CBCT. Sorry, I'm going to go through this very quickly. Intraoral scans, digital photographs, and today, of course, facial scanning as well. Then we're creating the virtual treatment for the patient. We're doing a presentation for the patient and the team so everyone understands the commitment, the impact of the treatment for the patient. We have control in the dentistry, in the restorative phase, which is guided dentistry, implants, guided implant surgery, guided restorative dentistry, and orthodontics. And then one of the most important things in the digital world is actually the control, or evaluating how successful or how accurate our treatment was that we proposed. So I'm going to run through this. He was unhappy with his smile. His teeth were disappearing. You've heard this before. They were becoming super sensitive to temperature over a relatively short time. He had poor maintenance over the last few years in terms of what had been suggested for him to slow the process down, and he was coming to me for a third or even fourth opinion. Right, I think we got to this slide when I was describing. So what we saw here is that he has an edge-to-edge bite, traumatic bite. He has definitely some attrition. You can see the facial surfaces of his central incisors. He's lost some enamel thickness. You can see the translucency now interproximally between the two centrals. He certainly has a sound periodontal situation. He has edge-to-edge bite on the upper occlusal. What we notice is he has some small areas of interproximal decay, nothing too serious, but certainly there are decay issues that need to be addressed. He has erosion, and if you look carefully, I'll show you the benefit of comparing photographs versus intraoral scans. So above on the right, you'll see there that I've made a note of, do we really need photographs anymore if we have the ability to scan our patients? And I'm not so sure about that. But certainly he has a loss of enamel on the palatal surfaces of his uppers and the occlusal surface, mostly of his first premolars. He has attrition, so he has been a bruxa. He has a traumatic occlusion, edge-to-edge bite in the anterior. If we look at the lower arch occlusal, what do we see? We see some decay. We see some failed restorations that are leaking, secondary decay. We see erosion again on the occlusal surfaces from the sixes forwards, less so on the incisal edges of his lowers. We see again attrition, and we have some anterior crowding. We can see anterior crowding between the incisors, the lower incisors. If we look at a lateral aspect, again, we can see the nature of his class 3, both skeletal and dental situation. We can see this edge-to-edge bite. He's in cross bite, even on the lower canine and upper lateral. And of course, this is going to be a problem relating to the treatment that we need to propose for the patient. So this is going to be a very important area that we're going to need to consider when we treat this case. From a facial point of view, and I've started with the intraoral pictures, and we have to remind ourselves as dentists, although we work entirely in the mouth, all dentistry, all restorative dentistry, certainly if there's any aesthetic changes that need to be made, need to start looking at the face. So dentistry as a whole needs to be facially driven. So this is actually the starting point, not the intraoral pictures. and we need to evaluate the face. We need to understand the face, and we need to understand how to evaluate the face. There was a beautiful paper written by a number of colleagues who are in our DSD team, and I'll speak a lot about DSD during this presentation. But what they looked at is how do we evaluate the face? Is it okay just to evaluate a static picture, or do we need to look at the dynamic situation? In other words, what's happening with the face as we go from rest to a static smile, which is how most of facial analysis is done, to a dynamic situation where we're seeing a lot more exposure of soft tissue and teeth. And that paper was in the Journal of Prosthetic Dentistry, and it was written by Eduardo Mann, in the DSD group, Bruno Pereira, Carl Stanley, and of course Christian was involved in that. So, and I have a lot to thank Christian Coachman for, I have to say. You know, he's made me understand dentistry in a way that, in all honesty, I didn't really realize the importance of designing and understanding about facially driven dentistry. So a big shout out to the DSD, the whole DSD team, in fact. So when we look at his photograph on the left, what we see at rest is that there is no tooth exposure. So in other words, he needs his teeth, his incisal edges, to be lengthened. If we look at the central picture, you can see that slowly he's starting to get to that static smile, and we're just starting to see the incisal edge. And then in the picture on the right, he's in a kind of in between, I would say, static and dynamic situation. And it was interesting to note that when evaluating patients in a static situation, 90% of females were showing soft tissue, gum tissue, and 74% of men, versus in a dynamic situation, it went from 90% in women to 100%, and from 74% in men to 90%, 95%. So it's super important to understand that we need the full range of exposure to understand the dental changes or the aesthetic changes that we might need to implement. And we can see from this case, we knew that we needed to increase the length of his central incisors or incisors, and as a result, he has a negative smile curve. Lengthening the incisors will reestablish that we see some amount of tooth structure at rest, and of course, reestablishing the smile curve will be part of the treatment plan. So if we look at a diagnosis of this case, and of course there's a lot more information that we would need to make a diagnosis, but let's jump into the diagnosis. He presented with erosion, and the erosion was generalized and without the loss of vertical dimension. In other words, wherever he had erosion and tooth surface loss, there had been compensatory eruption. His erosion actually was intrinsic, a reflux problem, predominantly also with the diet-related issues that he had. And yeah, all of our patients who have reflux problems, I think it's essential, once you've made a diagnosis, that they understand that needs to be controlled. And so all of our patients in our practice end up seeing both a dietitian and a gastroenterologist to control that. So it's not enough just to carry out the dentistry to fix the teeth. We need to really prevent the problem returning. So apart from that, he had some K, as we pointed out. He was periodontally sound. He had stable and asymptomatic TMJs, no muscular pain problems. He was a skeletal and dental class 3 relationship. He had a reverse smile curve. He had incorrect anterior tooth proportions, which resulted in the negative smile curve, the reverse smile curve. So if we looked at the erosion, and this is when I was saying, you know, do we need to start taking pictures anymore? Because actually, when you start evaluating your intraoral scans, you pick up more depth, three-dimensional depth on the erosive problem for sure than you do on a 2D photograph of the case. And if we look at the location of the erosion, although it's generalized, it's not affecting all the teeth in the mouth. So on the left side, as we can see, heavy erosion on the first premolars, very little on the second premolars, and on the centrals and laterals, well, there's practically no enamel left. We're right through to dentine, and a little bit less so, but obviously on the incisal edge of the canines, he has clearly a marked amount of erosion and attrition. On the lower arch, again, predominantly between the 6s, the 5s, less so on the 4s, and his main problem on the incisors was really more attrition than erosion. And the 7s are pretty much untouched. So this will also affect the treatment planning process, because I think it's super important to understand that we need to treat the problem, not necessarily teeth. And so, for instance, and I will expose some nice papers to you later on regarding vertical dimension. But it's important that, if a patient has localized type tooth wear, for instance, just in the anterior, that these patients can't be treated with full mouth rehabilitations. We have to understand that we can only treat the teeth that have been impacted by the erosive and attrition processes. So this played a very big part in deciding which way we were going to go. So when I discussed with him the previous treatment options that had been put to him, it basically provided the different options that he had available to him. And of course, I presented all of them to him, and at the end, we made a clear choice, which I think was in his interest. So the first treatment plan was no treatment, just prevention, and a night guard and control the erosion. So although when I say no treatment, I don't mean that he doesn't get anything. We control the erosion. So he sees obviously a dietitian to control the reflux and a gastroenterologist. We give him night guard to control the attrition. And this is in a way no treatment, but we're stabilizing the situation. So maybe we're deferring the need. But he had come to me for an aesthetic improvement, so no treatment in his case was not for him acceptable. Second option was one that had been given to him by one of the previous dentists who had seen him, which was comprehensive orthodontics. He was a skeletal class 3. He was dental edge-to-edge class 3 with crossbite, I think, on the laterals and the canines. And so one of the possibilities was comprehensive orthodontics, orthognathic surgery, followed by restorative dentistry, because obviously there was exposure of dentine from the erosion, so this would need to have taken place. A fairly aggressive treatment plan, but certainly one that was within the rights of treating the problems that he presented with. A third treatment plan, which in fact was something that had again been presented to him, was a conventional full mouth rehabilitation. And when we mean full mouth, we mean full coverage on 28 teeth. So again, it's an aggressive treatment plan, but it's going to address a number of the issues. The fourth treatment plan, which was in fact the treatment plan I proposed for him, was a minimally invasive approach, utilizing the increase in vertical dimension and minor anterior orthodontics. And so this was in fact the approach that we took. And as we go through it, you'll see exactly how I carried it out. So we've already highlighted the workflow that we follow. The first is to digitize the patient. We take records, we take intraoral photographs, extraoral photographs, intraoral scans. In this case, we didn't, I believe, need CBCTs. From the digitization process, we're going to do a 2D plan, and we'll go into this in more depth. From there, we're going to provide a 3D plan. From there, we're going to provide guided treatment, orthodontics, and restorative dentistry. And then super important part of treatment is, of course, maintenance. This is really as important as diagnosis and the treatment itself. So if we look now at the 2D design, What I love about digital dentistry is that, having moved away from analogs where, the design was created by our labs, and no disrespect to our technicians, I work with one of the most amazing technicians in the world, but their ability to recreate nature is limited. And so digital dentistry, what we do, what has been done, is we understand what beautiful teeth look like. And all that's happened is that we've copied these teeth. So we have now donators who have donated these natural, beautiful algorithms. And what you've seen there is a very good friend of mine. Again, he's in the DSD team, Carl Stanley, from LA, amazing dentist. And Kyle was the donator of the natural algorithms for this patient that we chose. And we have many algorithms or natural shapes and forms of teeth in the libraries that we use. So we use the DSD app to create the 2D design. And what does that mean? Is that it means putting the teeth in the correct position for the patient's face. So in other words, starting with the central incisors and understanding tooth proportion, midlines, smile curves, and making sure that we design a smile that is in harmony with the patient's face. And again, I'm going to refer to another beautiful article from the same team, more or less, describing facial flow and understanding that smiles are not mathematical. We need to understand that the face is not symmetrical, and that there are asymmetries that need to be built in to create much more balanced smiles that are, as I say, in harmony with the patient's face. And so it was a beautiful article written, and I'll refer to it. It's the facial flow concept, written by, again, Bruno Pereira, Eduardo Mann, the same team, Carl Stanley and Christian Coachman. And it explains exactly that. It is impossible just to use mathematics lines to design smiles. So with the app, we create this 2D design that is in harmony with the patient's face, borrowing natural algorithms, on this case from a very good friend who was one of the authors in that paper, Carl Stanley, and making sure that these teeth, proportion and position, fit the patient's face. And from here, we can start to think about occlusion and start to think about function. So every treatment planning process starts with aesthetic evaluation and an aesthetic understanding of where the teeth need to go. From there, we can move the 2D design into 3D design software, and we can start to see the changes that need to be made, designing with what we call transparency. So here you can see the patient's teeth underneath. You can see a superimposed 3D design, which is starting to allow us to understand exactly what are the implications of the dentistry, and what are the impacts on the patient from a biological point of view, from a soft tissue correction, or from a tooth preparation point of view, or even from an orthodontic or surgical point of view. So it's understanding the treatment necessary and the impact that it's going to have with that patient. So I'm very lucky to work with Planning Center at the DSD Planning Center in Madrid, who do my 3D designs. But what is really important is that while we're providing the 3D design, we're always referring back to the patient's face, to understanding that these changes are in line with what it is we're trying to do from an aesthetic point of view. We assess the pre-treatment, the post-treatment, and if we look at these two slides, what we see is that the 3D treatment, which is the white area, is overlaid on the pink, which is the model, and what we're seeing is that this is entirely an additive case. In other words, there is zero preparation necessary for this case. So when we go to the post-treatment, it's exactly the same. And from the upper arch, upper anterior teeth, we start to now plan the functional side of the design. And so in this case, we're going to open the vertical dimension. and we're going to talk a little bit about vertical dimension now because it's a critical factor in treating this patient. Bearing in mind that one of the proposals had been orthognathic surgery to basically a year to 2 years of fixed orthodontics, and then restorative dentistry. So when we talk about vertical dimension, we need to have an understanding of what is the starting point when we're opening vertical dimension for the patient. And so in my practice and the way we do it is we use centric relation as that starting point, because obviously we're now changing the occlusal scheme. And the reason that we use centric relation is it's because it's the most reproducible position to rebuild the occlusion. Okay, the most reproducible position to start rebuilding the occlusion, and it's the most stable position from a neuromuscular point of view. So all these cases we're going to determine centric relation. Remember, this case was he had no TMJ problems, no muscular problems, and so we were able to go straight into the planning process without having to correct any of those issues. So how do we register CR? I think this is, again, something that's a little bit of, a lot of dentists have difficulty with. In my practice, we use 3 methods. There's many different. There's chin guidance, bi-manual manipulation. We use the lead gauge, Lucia jig, and a decoy deprogram. Mostly in the leaf gauge and the deprogrammer. These are the most reliable in my hands in terms of getting the neuromuscular release and allowing me to register the joint position, as opposed to obviously a tooth-related position, which is centric occlusion. So the question is, and we will get to how much, but why do we need to open the vertical in a case like this? So obviously, when we went back to one of the first slides and we talked about being conservative, in order to be conservative and restore his posterior teeth, we need space for the materials that we will get to discuss later on as to which materials we're going to use. But we need space for these, and so by opening the vertical, we create the space for restorative material on the posterior teeth. We also improve the occlusal relationship. In other words, if you look at his anterior edge-to-edge bite, you can imagine that it would be impossible to lengthen these teeth and to provide a guidance pattern that would best protect the restorations and his dentition. So we also allow to control the steepness of guidance, which will help in functioning with his new restorations. And thirdly, of course, to enhance the facial integration. In other words, what we're saying here is that we need to increase the length of his upper anterior. He has a reverse smile curve. He's not showing enough tooth structure at rest. But without opening the vertical, there would be no space to increase the length of his incisors because of the edge-to-edge bite. So in his case, really, we're going to use the vertical dimension for restorative space for material to improve the occlusal relationship and to enhance the facial outcome or the facial integration of the case. So in all 3. When we talk about opening vertical, we have to understand the impact of posterior, anterior, and the pin of the articulator. Because all too often, I hear that the vertical was open 2 millimeters, and then when we ask the question, where was it open 2 millimeters? People look at me blankly, and they don't know the answer to that, because the relationship between the back teeth, the front teeth, and the incisal pin are roughly, and this is an estimate, it'll depend on the patient and the articulator we use, but if we open the posterior 1 millimeter, we're going to get 2 millimeters in the anterior and 3 millimeters on the incisal pin. And again, opening vertical, we understand that function, aesthetics, and biology. In other words, we're opening the vertical to create guidance. We're opening the vertical to increase the aesthetic outcome. And we're opening the vertical to respect the biology in terms of tooth preparation to create space for materials. So in a case like this one for this patient that we're presenting, in fact, he needed about 2 millimeters posterior, which was going to create a 4 millimeter problem anteriorly, which meant that, in fact, we were going to end up with a fairly large space between his anterior, his incisors. And so it was necessary then to, as you can see on the right, to restore the palatal surface of the uppers, which we had to because we had lost the enamel, and the incisal edges of the lowers, which had worn down also through attrition. So this is a beautiful article, again, Christian Coachman, Marcelo Calamita, John Coy, legends in dentistry. And for those of you who are looking at some references for vertical dimension, I'd highly recommend this article. It's probably the clearest article I've ever read on vertical dimension, International Journal of Aesthetic Dentistry, from last year. And really also what we're looking at is, as we open the vertical, not only are we gaining space for a new occlusal scheme and providing the patient with anterior guidance, certainly in this case, which was edge to edge, but also we're decreasing the steepness of the guidance, which will increase the envelope of function for the patient. So these are really important aspects and benefits of vertical dimension. Having said that, obviously, if we look at the class 1, class 2, and class 3 skeletal relationships, we have to understand that opening vertical in a class 1 and a class 3 is much easier than a class 2, because in a class 2 situation, as we open the vertical at the back, we lose contact in the front. So these are aspects that we have to understand on a case-by-case situation as to what is the correct vertical dimension that we can open the bite by, based on function, aesthetics, and biology again. So is it safe? The answer to that, I think, is overwhelmingly yes. There are many papers being written. These two, the one I've already mentioned by Marcelo and Christian and John, and again, I'd really recommend that. And another one by another legendary prosthodontist, Frank Spear, Advanced Aesthetics into Disciplinary Dentistry. Again, really, if there's two things you want to read about vertical dimension, these are them. But really, the outcome, or basically the consensus on vertical dimensions, is that it's safe. I've already said that. And that there are multiple acceptable vertical dimensions at which patients can be treated. And therefore, using vertical dimension as just a justification for treatment is not supported. And going back, I know I've said it 3 times, but the reason that we're changing the vertical is to enhance the aesthetic outcome, to enhance the functional outcome in terms of occlusal schemes, and to enhance the biological outcome in terms of being minimally invasive and creating space for our restorations. So we opened the vertical, and in this case, what do you see is that we decided to treat the teeth that needed treatment. In other words, the teeth that had been affected by the erosive process, which excluded the upper 5, 6, and 7, and the lower 7s. And yes, the 7s were left out of occlusion, but we all know the Dahl appliances and the Dahl approach is that if we leave these 7s over a period of time, they will erupt into occlusion. And we've just escaped the patient from needing a full mouth rehabilitation. So being conservative is always important. And again, I refer back to patient-driven treatment planning or patient-driven dentistry. Right. So in the 3D planning, of course, we can evaluate every aspect. We can evaluate the aesthetic outcome. We can evaluate the biological in terms of the impact on soft tissue, hard tissue, and function. So we can check overjets, overbites before we've done any dentistry. Once we've created this virtual treatment plan for the patient, it's now time to take it to the patient. Again, this is before any treatment is done, and provide the patient with a functional mock-up. In other words, we're visualizing three-dimensionally the treatment that we've proposed for the patient. And so the benefits of a functional mock-up is that it gives us the ability to check the incisal edge position, which is the starting point of restorative dentistry, to evaluate the smile curve, the midline, tooth proportion, gingival flow. In other words, if there's gingival changes, that they're in line with the dynamic and static smile of the patient, vertical dimension, guidance, and of course the biological impact or implications of the treatment. So we were in agreement, patient and myself, and now all we had to do, he had agreed to the treatment. All we need to do was choose material to provide the final restorative work. And we're fortunate these days to live in a world where we have so many options. Classically, if we look at materials for restorative dentistry, they fall into two groups, direct and indirect. So direct we know as composite resin materials. The benefits, of course, that they're minimally invasive. In fact, most of the time there's no preparation involved at all. The cost is much lower than indirect restorations. They're ideal for young patients because of the minimally invasive and no non-preparation or zero preparation or minimal preparation. And of course, maintenance, that we can maintain these cases should there be issues. The benefits, however, for indirect, of course, are that they're easier to control in complex rehabilitations. And that certainly was the case because the restorations were manufactured and the guidance and the occlusal schemes were controlled on an articulator and then brought into the mouth versus having to do them directly tooth by tooth in the mouth, which is a super difficult thing to do. Having said that, with all the new injection molding techniques available, yeah, I might have to readdress, whether, indirect is really the only method for complex rehabilitations. However, definitely for optimal aesthetic cases where there's a high aesthetic demand, for sure the ceramic is going to be beneficial, certainly over a long period of time. Operator skill, again, with the ability to do injection molding these days, I think that operator skill is more or less the same for indirect and direct. And of course, for mechanical demands where we have high functional demands, of course, ceramic is generally a better material, again, of choice. But what if there was one material that ticked both all the direct and indirect boxes, possibly maybe not cost and possibly aesthetics? And if so, is there that material that exists? And up until recently, the answer was no. But I think now 2 years ago, we were introduced to composite as a block material for CAD/CAM dentistry. And so this changed a lot of things for me when it came to making decisions based on material. So if we look at cost of milled ceramic versus milled composite, what are the implications? So I went to my lab and I asked them to run a test on milling Emax or lithium disilicate versus tetric or composite. And I wanted him to evaluate on a time basis because, as we know in most industry, time is money. And when we found that for Emax, designing, milling, sintering, staining and glazing, final firing and polishing for a restoration was basically around about 97 minutes. versus in Tetric, all they needed to do, same files, mill, much shorter time, and no finishing, just cut from the sprue and send it back to me. And so there was a 70% reduction, which was interesting, in laboratory time. And that 70% reduction in time obviously translates into a reduction in cost. So there was quite a drop in the cost to the patient. And now I had the ability to provide indirect restorations at a lower cost, which was really something that was appealing to me, especially in younger patients. And of course, we know that from a milling point of view, if we look at the ability to mill fine edges on ceramic versus composite, that the composite really handles much better than ceramic. And really one of the biggest advantages for sure, and certainly in young patients, is that 100% we can repair milled or indirect composite restorations where this is impossible in ceramic. And so the maintenance of these cases is really an appealing factor, and we can repair 100%, and I'll explain why in a minute. So the lower, we used some orthodontics. We decided to align his lower teeth, basically also to provide a much more smooth guidance pattern. So for the upper anteriors and lower anteriors, having aligned teeth versus malaligned teeth, but more importantly, just to provide some space that even with the opening in vertical, we were going to provide a stable guidance pattern for the occlusal scheme for the patients. 4 aligners was all that was needed. It was 8 weeks of orthodontics, but again, you know, this definitely affected the aesthetic outcome and the functional outcome. So treatment sequence for the case, bearing in mind that we're treating upper 4 to 4 and lower 6 to 6. I chose to do it like this, and there's a number of different ways you could do it. In the first appointment, we were guided tooth preparation of the upper arch, preparation of the lower posterior teeth. That was one appointment. Second appointment, we fit the upper restorations, we fit the lower posterior restorations at an increased vertical dimension. And so we created space in the anterior, which we rescanned the case to then redesign the lower anterior teeth for the new occlusion and for the new aesthetics. And then the third appointment to fit the lower anterior restorations, and I'll take you through each appointment sequence right now. So let's have a look at the first. If we're talking about material, let's remember about this, the main complaints or the problems that the patient had, and he was unhappy with his smile. So he wanted the best aesthetic outcome, and hence we chose ceramic restorations for the upper anterior teeth, EMAX, monolithic milled restorations based on natural algorithms from my friend Kyle from the DSD library. Then through the 3D design, we prepped the teeth, and then we borrowed back the 3D design to mill the restoration. So we didn't lose any detail. This is the key benefit of working in a digital workflow. Again, another legend in dentistry, a good friend of mine, Philip Girel, way back in 2003, understood the need for guided tooth preparation. And so never before have we been able to control the volume in the past, we would put wax onto a model, but we wouldn't understand how much wax model, whereas today, with good communication, we understand exactly how thick we need our ceramic restorations to be, because we have already chosen the color, we know the substrate, and so the communication to the lab is that we need ceramic restorations which are 0.3 at the gingival, 0.5 to 0.7 mid-facial, with a reduction of 1 to 1.5 millimeters, so that when we provide these depth cuts, we know when we move backwards that we're going to end up right on the surface of the enamel. That's super important. So we can see when we remove the mock-up that we've prepped through, that it's pretty much a prepless case. It's pretty much a prepless case. Having said that, when we look at the preps you will notice that I've gone into proximally. Why have I gone into proximally? Because we know that we had palatal wear, and we had to not only cover the facial surface, increase the incisal length, but also the palatal surface. So, the option would have been 2 separate veneers, or maybe the Violati 3-step technique. But, in order to be both conservative from a financial point of view, we had to break contact. But the key thing is that we've kept all the preparations in enamel. Retraction, standard intraoral scanning techniques. For the material choice on the low, we chose composite. We chose CAD composite. So in other words, milled composite restorations, because of a cost factor for the patient. And yeah, I think that maybe that it's nice to have a softer material versus the harder ceramic material from a wear point of view. The lower preparation, because it's composite, was pretty much zero. Remove the old restorations, immediate dentine sealing, a very slight bevel on the buccal and a butt joint on the lingual, and those were the preparations. So it was almost zero preparation, because why? Because we were gaining space from opening vertical dimension in a case like this. When we scan in centric relation, so in other words, remember that scanning in centric relation means there's no tooth contacts. It's a condylar position, not a tooth-related position. So we need the patient to be stable. So we create a CR jig. The patient's locked into that, and it's perfectly simple then to scan that bite in centric relation, because that's the best and most reproducible starting position. And we went through that. Then appointment 2 was the fitting of this, the restorations, indirect restorations up and lower, and then rescanning the case. So these ceramic restorations, first we're going to fit, of course, bonded, adhesive, indirect restorations require isolation. So the best isolation is a rubber dam, complete rubber dam. We keep the preparations in enamel. Why? Because we know that that's the most predictable substrate to bond to in the long term. We moved to a split dam, as you'll see as we went to the 3 and the 4. Everything gets cleaned with air abrasion before bonding, and then often we need to check contacts. That's one of the things that I found in milling all our restorations working modelless, is that sometimes we need a little bit of adjustment on the contact points. But this is a great little device from Bausch that allows you to really analyze exactly where the contact needs adjustment. So for the lowers, again, rubber dam. For bonding, AquaCare, we're going to clean the surface. Here we're going to use a selective etch, and we're going to use heated composite to bond the composite restorations, and we use exactly the same composite. So these are tetric, and there's many different brands of composite blocks on the market these days. This is from Ivoclar. So we're using exactly the same composite to bond the indirect composite restorations to the tooth. So what does that mean? It means that we're removing the cement interface. And also what does that mean is that if the restoration had a small gap or there was a small problem in the fit, we would just fill it up with composite. It's easier to control, and really it's when we're bonding indirect composite restorations, it's my treatment of choice. So once we had bonded the indirect restorations, ceramic on the upper, composite on the lower, we opened the vertical, and obviously we had now an anterior open bite. But yes, that was important because we needed space for the lower restoration. So here you can see the scan. We've got the upper ceramic restorations bonded. We have the lower posterior restorations bonded. And now all we need to do is create the lower anterior CAD resin restorations with zero prep, because we really will be able to finish these. We're bonding them with resin, And again, here's the benefits of digital, because when I spoke to the lab, I said, is it, and you can see how beautifully the edges of these mill down to a feather edge. So what I asked the lab to do is, when they were designing these restorations in design software, 3Shape software, is that if they were designing ceramic restorations with a minimal cutback to be layered, they have this option. And I asked them to cut back the CAD restorations. These were tetric, because again, I have to be honest that if you're looking at anterior restoration, ceramic is far better than composite. It's a little bit monochromatic, and so all they did is they cut it back ever so slightly with the software. I bonded them, and then I had this small space which I filled in with a enamel, directly enamel composite. So it was a freehand direct small restoration, and what that did is it customized the restoration from an aesthetic point of view, and it also allowed me to completely control the final occlusion of the case, the guidance of the case. So just by filling in, and to fill these in, you have the scaffold, we cemented them, and you just fill freehand this little bit of composite in. And as I say, the advantage is that really it customizes completely the aesthetics, because now we have a slightly translucent composite in the incisal area, but also it controls the final occlusion. So it takes all the pressure on the accuracy of the demands of indirect restorations. So I love this technique. So just to finalize, I know we've been through it quite quickly, and I'm more than happy to answer as many questions if there are questions on the case. So just to remind you, the situation he came in with, asking to improve the aesthetic outcome. He was complaining that his teeth had become sensitive because of the erosion, and he was complaining that they were disappearing, that they were becoming too short. So remember that this case, he was almost scheduled for orthognathic surgery and 2 years of orthodontics. We ended up treating the teeth that had been affected, that were going to need to be treated anyway. In other words, the teeth that had lost enamel. We ended up giving him back his smile, and we ended up giving him back a functional occlusion that was going to protect the rest of his dentition and restorations long term. Because of the controlled guidance pattern that we had dialed in to the design process in the planning. So, everything that we had planned in the virtual treatment was carried out in a guided way to provide the sort of outcome that you can see now. So we have beautiful guidance, we have anterior guidance, we have an overjet and overbite, we have beautiful tooth proportions, colors, minimally invasive, almost zero preparation. And we've covered all the exposed areas of dentine that had resulted from the erosion. And from a functional point of view, the guidance is steep enough. So, when we talk about guidance and we talk about the steepness of the guidance, the ideal guidance is to have it as shallow as possible, but that allows disclusion of the posterior teeth. In other words, that as this patient goes into a lateral excursion, that we want posterior disclusion of all the teeth. So here you can see that we've just got posterior disclusion, and so this guidance is exactly the right steepness. If there wasn't steep enough, we're going to have posterior interferences. If it's too steep, it's going to restrict his envelope of function. So these are the balances that we have to work with when we're designing the newest occlusal scheme for our patients. And remember, always starting in centric relation, because this is a reproducible and neuromuscular comfortable position for the patient to function. So those are the important take-home messages when it comes to changing in vertical dimension in a case like this. And of course, what's the most important thing for the patient? Remember his first complaint. He wanted to get his smile back. So facially driven dentistry, that the treatment planning starts with the face. From there, we can determine function and biology, but always starting in a facially driven way. So, again, this is how the patient is going to judge me, in all honesty. Yes, he's going to judge me that his teeth aren't sensitive anymore, but these are the pictures that he's going to look at and say, you did a great job. And again, we've given him back tooth proportion, we've recreated the smile curve, and from a functional point of view, obviously, we have a mutual protected occlusion, which is going to hold up in the long term. What was really cool about the case, I suppose, is the predictability. And was it important that we did it in 3 appointments? No. But was it a benefit? Of course it was. And when we look at analog versus digital, what I like to look at is that, in all honesty, I feel I'm better, I'm faster, and I'm cheaper. But what's more important is it's predictable, that it's the predictability that I have and the control of the case that I have in digital workflows versus analog. Of course, yes, we're more productive because we have more control. And if we're more productive, there's more profitability for everyone. So, but for me, predictability is the key. It's better dentistry, and it's, we have a better outcome when we're using these. So right at the beginning, I also explained a little bit about the quality control. It's understanding, how accurate was our dentistry, and did we achieve what we wanted to do? And so what you see here is that we had 2 scans. I had 2 scans of the patient. One was a pre-treatment scan, and the other one was the tooth preparation scan. And if you look in this slide here, I've overlaid in 3Shape. We have the ability to overlay the scans exactly. And what you see is that the lines are exactly the same. So what does that tell me? It tells me that we didn't prep the teeth. Okay, we didn't prep the teeth apart from interproximally. That the pre-treatment scan is exactly the same as the preparation scan. And so apart from rounding the edge, which we know that when we do milled restorations, that we have to have smooth rounded edge, that this was a minimally prepped or minimally invasive process. And then also that we have complete control on the case. In other words, what we did here is we have the prep scan, and we have a scan of the ceramic restorations. So I see now that I have clinical control, because remember, in the cervical area, we use 0.3 depth cuts. Okay, so what we've seen is that from the tooth to the outside of the ceramic, the thickness is 0.39. We've seen that in this area, we need 0.7 to 0.5. So we have complete aesthetic and functional control of the final restorations. Here we were lengthening 2.4, which was in the DSD. So if I go back to the DSD and I saw his existing tooth length, how much we needed to increase this case to give him the right proportion and the right smile curve was 2.5 millimeters. And what we've seen is that the control right from initial 2D design is that we have control in the thickness of the ceramic, in the aesthetic outcome, and of course in the functional aspects, that we now have guidance, the correct thickness of the material. And so the longevity of this case is as guaranteed as one can. So I hope you enjoyed that case. I hope you enjoyed the understanding of why and how working in a digital way is much more predictable from a facially driven, from an aesthetic point of view, from a functional point of view in terms of redesigning occlusion and changing vertical dimension, and from a biological point of view in terms of understanding the implications of tooth preparation, the impact on the teeth, and of course the final aesthetic outcome of the case. So for those of you who might know that I also lecture at the Implant Aesthetic Academy with a good friend of mine, Howie Glackman. You can follow us there, have a look at the Implant Aesthetic Academy website. We have some amazing cases and videos there. But yeah, I hope you enjoyed it. And if there are any questions, I'm more than happy to answer them. They're good?
So it was really a wonderful digitally oriented session, sir.
That's my pleasure.
So it seems It seems everybody present here is appreciating you, and we have got a beautiful response from the audience.
Okay.
So we have one question for you.
Yeah.
It's by Dr. Mansi. She asked, can orthodontic cases be considered in tooth wear using digital workflow?
Yes. So you can hear me?
Yeah, I can hear you.
Okay. Yeah. So in that one article that was written by Frank Spear about vertical dimension. So what he said is that if there was localized tooth wear, in other words, if the front teeth were worn, but they were in occlusion, okay, it's not possible to open the vertical dimension to get space to fix them. And then the only way to fix the case is with orthodontics, either to increase the overjet or intrusion to create space. But it's not possible to do it just with restorative dentistry. In other words, to cut the teeth down. So orthodontics is an integral part of treating these cases, and especially if we have, as I say, localized tooth wear. So in other words, if the anterior teeth are worn, but the posterior teeth are unworn and in occlusion, then for sure we have to do orthodontics, intrusion, and moving the anterior teeth to create space. So I would say a vast majority of my tooth wear cases that we incorporate orthodontics, because it means that also we can be minimally invasive in the tooth preparation.
Perfect. So I think we conclude here. Thank you for taking out the time to speak to us on this very interesting topic, sir.
My
And it
pleasure.
was really a great session, very informative.
Thank you very much. I hope you enjoyed it.
At last, do you like to say some words, sir?
I just say that I hope everyone is back to working safely. I just say that we had a discussion that we've started our practices a week ago, and I want everyone just to understand that they have to work in a nice, safe way for themselves and their staff and their patients. But I'm optimistic about dentistry, and I think I just wish everyone to be safe and look after themselves and their patients. So thank you very much for the opportunity.
Thank you, sir. So we'll be back with the next session in few minutes. For more information, with the links in the description box. Till then, stay tuned. Thank you.